But there's not many companies that are doing this. You don't see, the huge Ethicon, J&J, or some of these other large companies don't really have a division for ALS. And really, that's unfortunate with research, is you need corporate sponsorship also. But we're looking at a different, same device, but a different primary outcome. Our goal in ALS is to delay the ventilator. We know once a patient's been on the ventilator, from all of our other data, it's too late. And so we want to delay the ventilator by implanting earlier. And really, a lot of the data now kind of show what we have now. And so far, we have a 20-patient pilot trial that we finished in 2005. We finished a 100-patient pivotal trial. As opposed to the earlier things, is that it goes from pilot trial to pivotal in medical devices. And we actually have a 20-patient French study that we just finished at Sapetier, where Charcot obviously initially identified this. And obviously we've done some other kind of what we call compassionate use in ALS. So we actually have a pretty big patient population now that are utilizing the device. Now we're just following the data as we await some discussions with FDA. Our pilot trials, of the 20 patients that enrolled, 4 patients got too sick too fast. So we had an upper limit, or a lower limit, where we wouldn't implant. And our lower limit was 45% forced vital capacity. If you started dropping lower than that, you would fall out of our trial. In a typical ALS trial, because of the heterogeneity of the disease process, every ALS patient's different. You may have one that will live 13 years. You may have one that will live 18 months. And so what we wanted to do is actually each patient becomes their own control. So we followed each patient for 3 months with a battery of tests. Then we implanted them, and then we followed them afterwards. And really, if you look at this, our average forced vital capacity at implantation was 57%. What we took is all the people that failed all the other studies, because most pharmaceutical trials will actually stop at enrolling patients at 70% predicted. It's interesting in ALS patients, is one of my arguments I've been making, if you take sicker patients closer to death, you get faster results. If you take them earlier in disease, you have to follow them longer. So there should be a shift to actually doing research, especially when we look at the stem cell and other things, on patients closer to death. And if you can show a difference in that endpoint when you're closer to death, statistically, if you can lengthen it out, you get results faster. It can speed up your trials. We always had done where we do simultaneous PEG tubes. As a surgeon, interesting, the PEG was also invented at our hospital. My chairman is Ponsky. Ponsky PEG is what most of them are called. So we've always been very active as surgeons, and we implant all of our own feeding tubes, obviously, when it was invented in our hospital, and surgeons kind of control it now. So what we looked at is we initially looked at muscle thickness. We saw that the muscle got thicker with pacing, which means there's not many studies that show muscle gets stronger with therapy, and we measured by ultrasound thickness. Statistically, this is very small numbers. It's nothing I'd hang my hat on, but we actually showed by pacing we got the muscle thicker of the diaphragm. We showed that we could move more muscle. This has really become one of our key aspects, is that fluoro shot. Well, a patient take a breath, sniff, and we try to move it, and then we can stimulate the diaphragm. And if we move more diaphragm than the patient can, that means we can help the patient breathe. And again, that's what we look for. That's that upper motor neuron involvement. If they can't move it, but the pacing can, we can move it more. Obviously, in every spinal cord injured patient, they can't move it at all, and we can control the breathing completely. Long-term follow-ups of our safety trial, that we've now followed them in a long period of time. There's some key aspects. There's only 2 articles ever published on general anesthesia and ALS for patients, and they said all the patients died. So actually, it's actually changed our management. In our hospital now, if somebody needs to have their colon out, appendectomy, cholecystectomy, and they have ALS, we've actually have an anesthesia protocol that we just published that shows how to safely do general anesthesia and ALS. And that it's safe, and that you shouldn't be frightened if you need surgery. And you go to a local surgeon, they say, oh, you're going to die anyhow, you have ALS. Not really. If you have a hernia, you need your hernia fixed, you should get it done. That's something that we now can safely do. We actually saw that most patients utilized it much longer than they were supposed to, and over 50% of them said that they utilized it for sleep, which is something where we started going back to look at why that was occurring. This is our article in ALS that came out showing that it's fairly straightforward to do general anesthesia. But then we looked at the end result of most trials in ALS, and that's why we need a biomarker, and hopefully not industries will get that biomarker, is we don't have anything to look at. All we have is this forced vital capacity. And how many patients with bulbar symptoms can actually do that test adequately? It's not a good test. And so what we did look at in our trial, though, our initial pilot results, it looked good. Our patients were declining at 2.4% per month prior to surgical implantation, and post-implantation, they were declining 0.9%. When you statistically look at that, that's a 24-month improvement to the end result of survival, tracheostomy-free survival. That actually got us very excited, because that's pretty much unheard of in ALS trials. They have that much difference. Obviously, that was a single site, single group of patients. As you heard us say earlier, you can't really hang everything on one site, one group of 16 patients. But then we looked at why they died. Most patients with ALS still die from respiratory failure, but our patients weren't dying from respiratory failure. The lower one is actually a patient, you can see that burst of activity where you can see the patient breathe. You see the EKG, that little burst is a patient that's become locked in, that's still breathing on their own with no ventilator. And it's actually become something that we now discuss with our patients, now I do, especially in our European countries where we're approved, is that one is that most patients had that, when am I going to die? ALS is a terrible disease, and when I lose my ability to communicate, I'll choose I won't go on a ventilator. What if all of a sudden that choice is gone? We started looking at that in our patients because our patients weren't dying from respiratory failure. They were dying when they decided to turn off their pacing, which always brings in this moral and ethical things of withdrawing care as opposed to stopping it. Most of our patients never utilize a device 24 hours a day. They'd always use it 20, 22 hours a day. So sometimes it's easier to say, I'm just not going to restart a therapy as opposed to withdrawing a therapy. So we've seen a lot of interesting aspects in the end result of these ALS patients as we follow them to when they choose to die. Most of them don't get admitted to the hospital. It's interesting when you get short of breath and you have that emergency intubation, and most, if you go to a nice ALS clinic and you're a great support like ALSA, they'll get you prepared for that time where you're going to be short of breath, where you can't breathe. And you're already going to know beforehand, I don't want to get intubated. We know from all of our results is that once you're intubated, at the end stage of ALS, you're never going to get off the ventilator. And so that becomes that end point. But if you know all of a sudden that you can just, at home, we now tell our patients, we kind of know if we stop pacing, you're going to die in about 5 to 7 days. And it's at-home death. So it changes really what we look at. Statistically, though, it really messes with our results because we have patients withdrawing therapy to die, which wasn't in our FDA trial. So we now have great survival data and an on-off switch, which we didn't think we could do in our trial. We saw a lot of different things in the diaphragm. You can have differential right and left involvement. Weak diaphragms lead to this atelectasis problem, which leads to pneumonia. None of our patients died from a pneumonia to date yet. Very interesting aspect if you look at because we actually prevent posterior lobe atelectasis. We kind of saw this when Eric and I saw this first patient. We saw radial units, which was undescribed before. So we're describing something that wasn't seen before. And this nocturnal hypoventilation or central sleep apnea is actually there. We saw some other problems here. This is a patient with a forced vital capacity of 105%. You know who this patient is now. And you can see the left diaphragm's moving well. This patient allegedly has great breathing. The other diaphragm's not even moving. It's going in the wrong direction. So this great forced vital capacity can be 105%, but one diaphragm's completely gone already. It's already gone. And so that's not a good test for looking at. This patient wasn't eligible for a trial because he had to be below 85% predicted. But one diaphragm was no longer moving at all. And this is kind of, when we look at our pivotal trial, which we've now completed, and we're just following the data, and this is kind of the diagram of how we did this trial. Each patient was followed for 3 months. We followed them for 9 more months afterwards. We finished enrollment of our trial. We had 100-patient enrollment. These are the sites, our site in Cleveland, UH, Stanford, Henry Ford, CPMC, which is Bob Miller's group in San Francisco, Mayo Clinic, Methodist with Appel, Johns Hopkins University. So these are some very good aspects. We implanted our last patient recently. We had 20 demographics as typical for any ALS trial, a little bit higher PCO2 on patients, up to 58. Forced vital capacity is probably a little bit lower than most trials because we took patients later in their disease course. 28 patients fell out of their aspect. Forced vital capacity too high. They declined too rapidly. We had that cutoff. If we'd follow them for 3 months. If they went below 45%, we weren't allowed to implant. And then 12 patients, this was a relatively unfunded study. Interestingly, in all of our studies in diaphragm pacing, we had Medicare approval to pay for this operation. So it's an expensive trial once you get the surgery, but 12 patients' insurance companies wouldn't pay for it, and they dropped out because of the expense of that. And one patient withdrew, one investigator withdrew a patient for compliance issues. Overall, though, we've learned a lot from this multi-center trial. We've shown that all patients can be implanted at multiple sites. We now have 4 European sites implanting as routine. The electrodes will work. We've had no electrodes break. All the electrodes did what they were supposed to do, which meant that we could actually pace the diaphragm in these patients. So we've shown they can be duplicated at multiple sites. Our adverse events were minimal, actually. Comparing it to spinal cord patients, which are 50, and these 72 patients, the biggest things you may look in the fine print is this capnothorax, where air tracks your chest cavity. That just goes away on its own. It's just something we're tracking from that. We had no device erosions, migrations, lead impedance is out. We had 2 wound infections, which is, in surgery, you can't never not have a wound infection. That's acceptable when you're putting in feeding tubes. When we looked at the 30-day surgical mortality rate, we had no mortalities.